Good afternoon, everybody. First of all, I would like to express my sincere gratitude for the College of Physicians for inviting me to deliver this presentation. And again, I would like to thank Pulsar for changing my career from a surgeon to a physician or a cardiologist. Today, I'm going to discuss with you about a few cases that you see every day in your clinical practice with a management plan, especially in a peripheral center. I have selected this patient from my hospital. I'm working in Monaragala Hospital. I think it's my Monaragala Hospital serve as a good example for a peripheral healthcare center with limited facilities. My previous lecturer have given a great introduction about the current situation about the coronary artery disease and its management facilities in Sri Lanka. And I think you can see like you can like imagine the real situation compared to other countries. But in my objective is to open your eyes to see a hidden area of acute coronary syndrome. I would like to discuss with this as a case-based discussion. The first case, I have selected a simple, straightforward case. I think you have seen these kind of patients every day, even during your medical school care. My first patient he's a 55-year-old male patient, presented with central chest pain, lasted for 5 hours. He has his medical history include type 2 diabetes mellitus, hypertension, and hyperlipidemia. On admission, his blood pressure is 80/60 and heart rate was 90, and he had bibasal palpitation suggestive of cardiogenic shock. This is his ECG. I think I don't have to explain describe the ECG. It's clear that the patient has ST elevation, myocardial infarction. This patient admitted to our hospital, and we have thrombolized with the streptokinase because we didn't have PCI facility. And we have kept this patient while monitoring. And unfortunately, even after 1-2 hours, the patient's pain was persistent. And the ECGs looks like this, and they are like persistent ST elevations. This is, I think, typical case scenario we see in current days because we don't have tenosynovial waste. We are thrombolizing streptokinase. And this patient wanted to transfer to a center where PCI facilities available. I think as previous speaker has told, that is the limiting factor for us. But fortunately, this patient had a chance to go to a PCI facility center. I'm not going to talk about the ST elevation myocardial infarction, but I want to take this as an introduction to my presentation. You all know that ST elevation myocardial infarction represent myocardial ischemia caused by complete occlusion of the coronary artery because of atherosclerotic plaque rupture and subsequent thrombus formation. This is a medical emergency because once the coronary artery is completely blocked, the blood supply to the myocardium gets cut off. Then the second by second myocardial cells get damaged and died. Once these cells get died, these cells cannot be regenerated. Therefore, the patient will lose myocardium once this complete obstruction happens. Therefore, as emergency physicians must thorough at first recognizing STEMI and early as possible, and prompt diagnosis is very important, as well as early reprovision of acute coronary occlusion is important to reduce the myocardial damage, ultimately to reduce the morbidity and mortality. First hour is the golden hour, and maximum we have maximum 3 hours. Because as the previous speaker show you with a nice illustration, after 3 hours, actually we have 80% of the myocardium is lost. Therefore, there is minimum chance of saving the myocardium. Therefore, we have only 3 hours to diagnose the disease and treat appropriately. Just to show you that ECG criteria in diagnosing ST elevation myocardial infarction, since it is very basic, I am not going to explain these things. It clearly says classically STEMI is diagnosed if there is more than 1 millimeter ST elevation in 2 contiguous leads. I just want to show you the juniors doctors what is contiguous leads. Our ECG we can divide it into families. The families include inferior family, lateral family, anterior family, and posterior family. We divided the ECG into families because to identify the contiguous leads. As an example, inferior family include 2-3 AVF leads. These 3 leads are considered as contiguous. Therefore, if there's 2 and 3 leads get ST elevation more than 1 millimeter, we consider it as ST elevation MI in inferior segments. And these families represent specific region of the heart as well as specific artery of the coronary vasculation. Likewise, anterior family include lead V1 to V4 and the lateral 1 AVL, V5, V6, and posterior leads include V7 to V9. Usually it is not represented in the 12-lead ECG, but we can get idea when there's some other ST depression changes in the V1 to V2. The management of STEMI, again, I just briefly explained. There are numerous studies has done regarding the management of ST elevation myocardial infarction, and they are based on these population-based studies, the major cardiology bodies actually have published their guidelines. We refer basically European Society of Cardiology guidelines and the American Heart Association guidelines. They have published guidelines, and recently also they have updated ESC in 2023 and American Heart Association very recently in 2021. The important thing is both these major cardiology guideline making bodies highlighted the importance of immediate catheterization and revascularization for patients with ST elevation myocardial infarction, because they have considered it as class A, level of evidence A, recommendation for STEMI patients. And also, if these patients cannot be sent for the primary PCI or mechanical revascularization, we can give medical thrombolytic therapy. That is also considered as level class A, level of evidence A recommendation. However, always the PCI is better than medical thrombolysis. This is a summary of the ST elevation myocardial. Whenever you get a patient with chest pain suggestive of ST elevation myocardial infarction, we have to ask a question from yourself whether the patient can be sent to a center where PCI facilities available within 120 minutes. You have to diagnose the patient within 10 minutes. Within 10 minutes, you have given only 10 minutes to diagnose patient, clinical assessment, and do the ECG and diagnose. You have to diagnose within 10 minutes. And if the hospital have PCI facility, you have to directly send patient for PCI within 60 minutes. And if you don't have PCI facility in a hospital, again, after diagnosis, after 10 minutes, you have to transfer this patient to a PCI available hospital if you can arrange the transfer within 120 minutes. If you can't arrange the transfer, you can give medical thrombolytics. After giving medical thrombolysis, if it is fails, that clinical symptoms is not settled and the ECG is, if there's no more than 50% reduction of the ST elevation, you have to again transfer this patient to PCI available center. That is the recommendation, but as our previous speaker said, we don't have such facilities in our setup. This is I'm showing just like meta-analysis showing that primary PCI is always better than medical thrombolysis, and even the rescue angioplasty is better even after medical thrombolysis. This is I just want to show you our patient's angiogram, because I told you that our patient initially we gave medical thrombolytics, but since it was failed, we sent to transfer to Kandy Hospital. We did the angiogram. I just show you the angiogram. Before showing the patient's angiogram, I will just show you a normal angiogram, because you may have not seen an angiogram before that. And this is the image shows the left anterior descending artery. And you can see that nice contrast filling of the coronary artery. That is a normal coronary artery angiogram, what we see. This is the right coronary artery. That is the normal right coronary artery. I'm showing this because this is our patient's angiogram. You can see this is the anterior descending artery. It's completely blocked at the proximal vessel. I just show you this because when I see this image, I become sweaty and my heart rate increases and I become panic, because I know that if I have not opened this vessel within 3 hours, patient and whole anterior left ventricle, the major part of the left ventricle died, and patient become ill, and patient's life can be in danger. And even though he survived, we can save his life, he will end up with the heart failure with the low ejection fraction. And if it is a young male, he will become a dependent person in the country. It will affect for the whole country economy. And this is again angiogram showing that another view. You can see that completely blocked left anterior descending artery with the patent circumflex and ramus intermediate artery. This is actually our patient, and that patient was fortunate to have primary PCI, and this is what actually we do in the cath lab. And this image shows we have inserted a wire and we kept a balloon there, and we dilate the balloon first, and then we deploy a drug eluting stent. And this is the final outcome. You can see that after deploying the stent, the patient again that lost left anterior descending artery, you can reappear. That is what actually we expecting. Our heart rate become normal and our setting will settle and our anxiety settle once we see this image in our patient. That should be our target, but still we have some challenges. Especially the periphery, this ideal setup we cannot be performed because even though the medical thrombolysis is the option, we have streptokinase these days because tenecteplase it costs about 180,000, but streptokinase about 20,000 or 30,000. Therefore, the government is currently purchasing streptokinase. But streptokinase problem is vessel opening rate is low. It is like 40 to 50%. But tenecteplase it is more than 90%, especially in Sri Lankan population. Therefore, we are facing a problem with streptokinase, and also there is like complications such as allergic reaction and bleeding risk is high with the streptokinase. And even for the transfer, if I like consider the Monaragala hospital, the Kandy is the nearest cath center for us. It take about nearly 4 hours to transfer from Monaragala to Kandy. It is a Google map shows, but you know that taking patient from ward to ambulance, it will take another 2 hours. Therefore, we take like more than 6 hours to like transfer one patient to Monaragala. And facilities also, we don't have like sophisticated facilities like this. Instead, we have experience like this. This is our way, like from Monaragala to Kandy. And you don't believe that it is about 150 kilometers. There's a 30-kilometer segment. You won't get, even we don't have mobile signal. Therefore, if there's any like danger like this, even you can't like get help and you can't inform your loved ones before die. Therefore, definitely it is not only for the endanger for the patient, the whole team is in a threat of like losing life when you are transferring patients. That is the real situation in periphery. Okay, that is the background about our history. Now I would like to explain few other cases. That is what I want to open your eyes. This is my case number 2. This is Mr. A. Like he's a 21-year young male patient presented to the emergency department at 3 a.m. with 3 hours history of crushing chest pain. There's no previous history of diabetes, hypertension, dyslipidemia, or family history, but he's a smoker. I think especially in Monaragala, most of them are smokers because locally available like illicit drugs are available. And blood pressure, the hemodynamics are stable and examination also unremarkable. This is his ECG. This is real ECG. This patient admitted about, I think, 2 months ago. You can see there is no ST elevation myocardial infarction here. There's no clear ST elevation, but there are hyperacute T waves. Apart from that, there's no significant ECG changes, but this is not a complete ECG. If I can remember, he had mild ST depression in the inferior leads in the other leads because I am showing only chest leads here. I would like to take another case. This is again Mr. K. He's a 43-year-old male presented with history of central chest pain for 2 hours. He has diabetes mellitus, no history of hypertension, dyslipidemia, no family history, and he's again a smoker. His blood pressure, and heart rate is stable. Other examination, clinical examination also unremarkable. This is his ECG. Again, there's no clear ST elevation MI. But again, this patient chest lead illustrated that there is hyperacute T waves. Apart from that, there are some upsloping ST depression in chest leads. Usually, we consider the ST depressions are horizontal and downsloping ST depressions are ischemic, but here it's upsloping ST depression. This is another case. These all cases are 2 cases admitted to our hospital very recently. Again, 64-year-old male patient presented with OPD with history of chest pain for 2 weeks. He's on treatment for diabetes, hypertension, and hyperlipidemia. Hemodynamic parameters are within normal range. He had like fortunate to have troponin. It came as negative. And this is his ECG. What is this? Is it typical ST elevation, MI or not? Okay. Okay, considering those 3 cases, what is your diagnosis? Is it STEMI or non-STEMI? Because we talk about STEMI, we talk about primary PCI for STEMI patients, and we are going to like arrange wagon wheel like system and the cath lab facilities for STEMI patients, not for non-STEMI. Is it STEMI or non-STEMI? I show you the STEMI criteria. STEMI criteria is the more than 1 millimeter ST elevation in 2 contiguous leads. Okay, what is your plan? Does this? These are the options. This does not fulfill STEMI criteria. Therefore, no PCI, no thrombolysis, managed as non-STEMI. Are you safe to manage this patient as non-STEMIs? It looks like STEMI even though there are no ST elevation. Therefore, arrange PCI if available, or if not, thrombolize and then transfer to PCI center. Okay, or you can do troponin and wait for confirmation. If troponin positive, you can manage accordingly. or arrange echocardiogram for additional information. Or it's unlikely ACS, therefore look for alternative cause for ECG changes such as hyperkalemia causing hyperacute T waves. Troponin, it takes 2 hours to become positive after the onset of the chest pain, and also after sending a blood sample to the lab, it again takes about 1 to 2 hours to take the report. Therefore, at least it takes 4 hours after admission. We can't keep patient with the suspecting STEMI for 4 hours because you have maximum 3 hours to save his myocardium and save his life. Echocardiography, it is recommended that echocardiography should be available in emergency room because in cases of suspected acute coronary syndrome with diagnostic uncertainty, we can do transthoracic echocardiography to see the changes, especially to assess the regional wall motion abnormalities. However, we cannot wait until the echocardiogram is performed to treat if it is suspected as ST elevation myocardial infarction. The echocardiography has additional benefits such as we can exclude other causes for chest pain such as aortic dissection and pulmonary embolism. This is our second patient, young male who presented with central chest pain for 2 hours echocardiography. If you can see, this is the cross section of the left ventricle. We call it as short axis of the left ventricle. If you can clearly see the upper part of the left ventricle, that anterior wall is contracting less compared to the other segments. And also this is the long axis view. The upper part of the image is showing the septum, and that's the posterior wall. Septum is less moving compared to posterior wall. Therefore, we can get additional information. Actually, after doing this echocardiogram, we thrombolize the patient considering it as complete coronary occlusion. But in a peripheral center, we cannot ask echocardiogram for each and every patient because for the Monaragala district, for the whole district, the only Monaragala hospital have cardiac facility. They have only 1 cardiologist and 2 medical officers are available. Therefore, it is not a good option to ask echocardiography for all the patients. However, I think it is considered by the College of Physicians as well. We can train the emergency department medical officers for a basic echocardiography to assess the basic things to exclude the pericardial effusion, to assess the pulmonary embolism, and basic regional wall motion abnormalities. Actually, in our region, we have few physicians who can do basic echocardiography. Sometimes they do echocardiography. And once I can remember, there's a patient admitted with a severe pericardial effusion. The physician has did the echo and he aspirated and transferred Monaragala for further care. Yeah. Okay, anyway, still we don't have a diagnosis for our patient. Is it STEMI or not STEMI? This is again our patient. That patient we thrombolized and transferred to Kandy Hospital and found to have there's a tight stenosis in the proximal LAD. If you can see in the proximal, very proximal segment of the LAD, there's a tight lesion. There is another view of that same patient showing that a tight stenosis. Yeah. When the acute coronary syndrome, traditionally we divided into ST elevation MI or non-ST elevation myocardial infarction. STEMI is a complete obstruction of the coronary artery. With ECG, there are ST elevation and transmural involvement of the myocardium. Because of the complete obstruction of the coronary artery, these patients want immediate cath lab to open that vessel. Otherwise, they lose their myocardium and they will lose their life, and they will end up with heart failure if they survive after MI. But on the other hand, non-ST elevation myocardial infarction, they don't have complete obstruction. They have partial obstruction. Therefore, they don't need urgent revascularization. We can manage medically to prevent the propagation, to prevent the development of ST elevation MI. We can manage medically, and leisurely we can send these patients to for the cardiac catheterization for assessment of the coronary artery. Usually, their EC changes are ST depression and T inversion. They don't have full thickness involvement of the myocardium. They have partial thickness involvement of myocardium. But studies have shown that large number of patients, nearly 1/3 of patients we are treating as non-STEMI, have complete obstruction of the coronary arteries. They are called STEMI equivalent. Okay, what are going to do those patients? Okay, I'm going to highlight these group of patients in this presentation. That was my actually objective. These patients typically does not present with ST elevation myocardial ST elevation in ECGs. Therefore, if we see the only ST segment elevation patients are selected for catheterization of primary PCI, we lose large number of patients. An absence of classic ECG pattern may delay the detection of coronary occlusion, like if we have not see this specifically, and appropriate immediate perfusion treatment. This delay cause and study shows twofold increase in the short-term and long-term mortality. Therefore, if we use solid terminology of STEMI and non-STEMI as a gatekeeper for reperfusion decision, we under-recognize large number of patients who need immediate cath lab interventions. That's why a new terminology came as occlusion myocardial infarction. It's called OMI, and if it is non-occlusive, NOMI. OMI refers to acute coronary occlusion or near occlusion resulting in transmural myocardial infarction and tissue death. The term encompasses both STEMI and STEMI equivalents. The current STEMI non-STEMI paradigm is imperfect and needs to be replaced by NOMI since it deciding whether the ECG qualifies for acute perfusion or not. Okay. Therefore, there is a special group called STEMI equivalents. STEMI equivalent represent coronary occlusion without meeting the traditional ST segment elevation criteria. These divergent patterns require the same level of urgency and treatment as traditional STEMI because they have complete obstruction of completely occluded coronary arteries. They do have ECG changes. Okay, then what are these STEMI equivalent? Those are the left bundle branch block, Whelan syndrome, De Winter syndrome, LMCA pattern, left main coronary artery pattern, and hyperacute T waves. These are the three patients I have presented to you earlier. One patient has hyperacute T wave is ST depression, that is Whelan syndrome. Another patient hyperacute T wave, another patient is the Whelan syndrome. Yeah, these are the three patients. Left bundle branch block, the recognition of acute coronary occlusion in LBBs remain difficult. Traditionally, we recommended thrombolysis of primary PCI for new onset left bundle branch block, but it is not like that. Not like that because all new LBBs are not due to myocardial infarctions. Therefore, several studies have systematically evaluated the value of different ECG findings in left bundle branch block. And in 1996, Scarbosa looked data from Gusto-1 trial, and he has found interesting thing, and he has prepared a scoring system to differentiate LBB associated with MI and LBB as not. It's a normal LBB. And these are the three main criteria. One thing is the concordant more than 1 millimeter ST up, that gives 5 points, and discordant more than if there's 2 millimeter ST depression, and excessive ST elevation with the discordant pattern, that is if there's more than 5 millimeter ST elevation. And according to that, he has made a score, and based on that, we can differentiate LBB with MI and without MI. And there were some drawbacks on this scoring system. Therefore, it is later modified by Smith. Therefore, now we are using Smith modified Scarbosa criteria. I'm not going to discuss these things. This is I'm showing one example of left bundle branch block with MI. Here you can see excessively discordant stimulation with ST depressions. And again, this is another example. The other STEMI equivalent is the hyperacute T waves. Tall peaked hyperacute T waves, it emerged as the initial ECG changes of ST elevation myocardial infarction. They usually short-lived, that rapidly evolves into ST segment elevation. Therefore, we have to take this as a critical patient, and we have to act quickly to send this patient to cath lab, and we have to alert the cath lab system and send for immediate perfusion. If it is not available, cath lab available, we have to think about alternative. The third thing I would like to show you is the De Winter's T wave. It was first reported by Dutch professor of cardiology Robert J. Winter, and it has the typical ECG pattern is the upsloping ST segment depression at the J point in precordial leads and transitioning into tall symmetrical T wave. This pattern suggests again proximal LAD occlusion demanding prompt revascularization. The proximal LAD occlusion we consider it as important because if that proximal LAD lesion get blocked by thrombus formation, the large area of left ventricle myocardium will get died. That's why we consider proximal LAD lesions are very important. Typical STEMI morphology may proceed to follow the De Winter pattern. This is, I'm showing you one example ECG of a De Winter syndrome. And other is the isolated ST elevation in AVR. Isolated elevation in AVR alongside with widespread ST depression could signify severe obstruction in the left main coronary artery. This pattern flags a high-risk widespread myocardial danger indicating immediate reversal. When there is a left main coronary artery obstruction, if there is again thrombus formation and the patient develop MI, all left anterior descending and circumflex artery will get obstructed. Therefore, patient will get massive damage to the myocardium. This is ECG showing that AVR elevation with widespread ST depression. Oh. This is, I just show you that one of our patients coronary angiogram. If you can see, left main coronary artery divided into left anterior descending and circumflex, and distal left main coronary artery, and as well as the ostial LAD and circumflex has severe stenosis. These patients are very high risk patients. At any point they can develop MI, and if they develop, definitely they will develop VT and cardiac arrest immediately after MI. Therefore, these patients need immediate attention. But one important thing I also want to tell you that the AVR elevation and widespread ST depression happens when there is a diffuse ischemia to the myocardium. It is not only due to the coronary artery disease. If there is like a severe hypovolemic shock causing diffuse ischemia to the myocardium, they will get AVR elevation and ST depression. And also, if they have like multivessel disease, severe triple vessel disease, they get AVR elevation and ST depression. Therefore, you have to assess the clinical picture of the patient and decide on whether the patient is going to cath lab or not. Balance syndrome, that is also, it's one of the common presentation to our hospital. Balance syndrome has deeply inverted or biphasic T waves in lead V2 to V3. It again highly specific for critical proximal stenosis of LAD. Again, I would like to highlight that if this patient develop MI, blocking the left anterior descending artery proximally, they will lose large part of the myocardium, mainly the left ventricle myocardium, that is a pumping chamber. Therefore, they will lose heart function. There are two types of Whelan syndrome, ECG changes. One thing is the biphasic T wave, and other one is the deeply inverted T wave. The commonest is the deeply inverted T wave. And most importantly, T wave changes can evolve over time from type A to type B. Therefore, one patient, once we can see as a type A, and when in the next admission, we can see as a type B. Whelan syndrome patient may be, one important thing, they may present with pain-free, as well as they may have negative troponin or minimally elevated troponin. If you can remember, my last case I presented was the patient presented with 2 weeks history of chest pain with that Whelan's ECG. At that patient's ECG was have Whelan's changes, but troponin was negative. Even though the troponin is negative, patient pain-free, we have to take this patient as risk patient because the patient, this patient can develop anterior MI at any time. Therefore, patient need definitive treatment is the coronary angiogram plus minus PCI or bypass surgery. This is again one of our patients. This patient again presented with ECG showing Whelan syndrome. Our two patients actually. I think whole angiogram is in this video. Maybe I cannot play. Yeah, you can see that proximal LAD, there's a titration. This patient had angiogram. This is right coronary artery is normal, and we insert the wire. This is after deployment of stent that obstruction is relieved. Then only the patient is free from danger. For the STEMI equivalents, the guidelines recommendation is still the major guidelines. They talk about the STEMI equivalents, but there's no clear recommendations. But in the ESC guidelines, they have considered these patients as high-risk non-STEMI patient, and they recommended immediate catheterization. And also American Heart Association, there's a recent expert consensus published in 2022. They also suggested invasive angiogram. But None of these guidelines have talked about thrombolysis for these patients. Therefore, we don't have clear guidelines for the thrombolysis. In a peripheral center like us, we don't have PCI facility. Therefore, we have to assess patient clinically, and depending on the patient situation, we have to decide on whether are we going to thrombolyze or not. Usually in my practice, I thrombolyze when the clinical picture is matching. If patient presented with hyperacute T waves, D Winter syndrome and left ventral branch block with scarbosa is positive. But for the Whelan syndrome, it is not completely obstructed vessel. Therefore, I won't thrombolize. I will give enoxaparin and I will discuss with the PCI center and transfer patient before discharging to the PCI available center. That's what I want to discuss with you today. In a summary, patients with an acute coronary occlusion need immediate reperfusion via cardiac catheterization or fibrinolysis. Traditional instruction use ST segment elevation to detect acute coronary occlusion. There are a large number of patients, nearly 30%, who have acute coronary occlusion without having traditional ST segment elevation in ECG. They called STEM equivalents. These STEM equivalents group require the same level of urgency and treatment as traditional STEM. Thank you very much.